Welcome, everyone. We're just letting people into the meeting now, and we'll get started in a moment. Okay, welcome everyone. Thank you for joining the Community Engagement Alliance Consultative Resource, or CEACR, speaker series today. I want to let everyone know that this session is being recorded. And before we begin, we want to help everyone choose their appropriate Zoom settings for the event. So I'm going to turn it over to our interpreter staff from Linguaficient to let everyone know how to access your interpretation features in Zoom. We do have both Spanish and ASL interpretation today. So Andrea, please.
Thank you, Emily. Actually, it'll be Annabelle doing announcement. Thank you so much. Welcome, everyone. Buenos días, bienvenidos, o buenas tardes, depende de dónde están. Bienvenidos. I'm going to do this message in English and in Spanish. So we are having a bilingual meeting. We'll be offering interpretation into Spanish and from Spanish into English. So to do this, we ask that all of you who are joining select a language, whether you are bilingual or speak Spanish or English. We're going to ask that you select the language that that pairs with the way you'll be participating. So if you're joining us via a computer, you'll see a globe icon on the bottom right-hand side of your screen. Select that globe icon and choose English. And that's all you need to do. You don't need to do anything else. And this is so that you can hear if somebody participates in Spanish, either with a question or a comment. Buenas tardes, si ustedes están participando a través de una computadora, queremos asegurarnos que puedan acceder a interpretación. Así que si pueden fijarse en la parte inferior de su pantalla, al lado derecho, van a ver un icono de un globo terráqueo. Seleccionen ese globo terráqueo y seleccionen español. Después tienen la opción de silenciar el audio original. Esto es para escuchar solo las intérpretes.
Okay, this is a test while instructions are being provided in Spanish for language access.
Tablet or a smartphone, you can touch your screen lightly right now. You'll see a 3-dot menu and select that 3-dot menu. It will take you to another menu that includes language interpretation. Select English and then select done, and that's all you need to do. Si están participando a través de una tableta o un teléfono inteligente, toquen su pantalla suavemente, verán un menú de 3 puntos en la parte inferior de su pantalla, seleccionen ese menú, luego eso los llevará a otro menú desplegable que tiene la opción de interpretación de idiomas, seleccionen español, igual tienen la opción de silenciar el audio original para no tener que escuchar inglés al fondo. Y luego seleccionen finalizar o done y están listos para participar. Pueden hacer sus preguntas en español y si tienen algún problema tecnológico, pueden usar el chat para dejarnos saber. And so if you have any issues with the technology to access information, please let us know using the chat, and we have instructions in the chat as well. Thank you so much, and I'll turn it back over to the good folks from the CEACR series.
Wonderful, thank you, Annabelle. So I'm Emily Finley. I'm a program coordinator from Community Campus Partnerships for Health, or CCPH, and CCPH partners with University of Pittsburgh to support the CEACR project. So inclusivity is the central component of CEACR activities. Our team works together with clinical trial teams, as well as our Community Engagement Alliance colleagues and their community-based affiliates to better understand how to bring underrepresented communities into critical health research opportunities. So we serve as connectors and amplifiers of community needs and best practices to bridge the divide between institutions and communities. CEACR hosts one-on-one consultations, conducts analyses of recruitment and outreach approaches, holds information sessions like this one, and convenes focus groups to review public-facing research materials for cultural appropriateness. You can visit our CEACR website to submit a consult request or serve on an expert panel. So we have a wonderful panel lined up for you today to discuss caring for the caregivers in community partnered research, considerations for research reciprocity. Next slide, please. So I'd like to welcome our moderator for the event, Ann Carver. Ann joins us as a lead researcher from the Arizona SEAL team and works at the Arizona State University School of Social Work. And Ann will announce today's panelists, and then we will dive into the discussion. So thank you, Ann.
Thank you, Emily. It's great to be here on behalf of CEACR and on behalf of the community for which we've served over the last few years with respect to this COVID-19 pandemic. I am thrilled to bring to you some panelists, and I'll let them say a little bit about themselves, but it's Dr. Stephanie May, Richard James, Dr. Gorman, and Dr. Portia Jackson Preston. You know, we've been doing research and engaging with the community in order to understand COVID-19 and the impact of COVID-19. And while we were interested in things like uptake and whatnot, what we've learned is that our workers who are serving this community are doing so in many selfless ways and creating quite a bit of burnout. Today, we're going to talk about that. And before we begin, I just want to ask a question to our panelists as they introduce themselves. What prompted you to agree to join this particular conversation about caring for caregivers? And let's start with, well, anyone can start on the panel.
Good afternoon. I am Dr. Stephanie May, the Executive Director for the Bridget Austin Community Center. And we have been connected and stayed connected with our participants for the entirety. Even during the darkest days of the pandemic, we had to figure out ways to bridge the gap between our faith-based organization and the greater community. And so we ask simple questions: what do you need? And once those voices emerged, we began to reach out to partners to provide the goods and services that our community was in need of. So what drew me was that this feels like an extension of that, because we feel as if now COVID is behind us. But no, the after effects and really the initial effects of COVID, the residue is still there. And the voices of the people that we've invited to this session, we've been asking them all along, how can we better serve you to make certain that you don't fall through the cracks? So in response to that, that is why I'm here today, because our community is still definitely being impacted by the effects of COVID-19.
Thank you, Dr. May.
Thank you.
I'm happy to go next. Thanks, Dr. May. So I come, through my experience over the last sort of several years of working with patient and family engaged research organizations in the field of congenital heart disease. One of the things, we had, a wonderful sort of first in-person for several years meeting a few months ago. And, one of the things that startled me in that meeting, which is, what I thought about when I saw the invitation to this get together, was that I had brought with me sort of a number of our parent stakeholders, to the meeting, because we're very, the National Pediatric Cardiology groups sort of very enmeshed with having parents and families, and increasingly patients drive the research agenda. But I was surprised when a couple of parents said to me that it was so hard to be there. They'd had to leave, they were overwhelmed. There was some, partly in one case, they'd suffered a bereavement in the kind of the COVID period. In another case, the experience of having a chronically sick individual in their families during COVID was, so overwhelming that coming to this meeting just, it just surfaced all kinds of trauma and unpleasant memories and experiences, and they weren't able to participate fully in the proceedings. They weren't able to contribute the way that we would have most valued. And I left that meeting with the question to the organizers, what are we going to do next time we get together to make sure that, these particular stakeholders are taken care of?
Thank you.
I can go. Hi, I'm Sarah Gorman. I'm the CEO of a nonprofit called Critica, which focuses on developing and testing new methods of counteracting health misinformation. And I was drawn to this panel because over the past several years, as part of the pandemic, I've really focused on, I'm writing a new book actually about trust in the healthcare system and in public health and how that's evolved over the pandemic. And what I've noticed in consulting with and working with public health officials at state levels and at the national level is that people feel really burnt out, in part because they know that the trust in the communities is low in the public health officials and the healthcare system. But they also don't feel like they have the tools to intervene in that. They feel like they don't have the time, that it's not prioritized by leadership in their organizations. And so they feel sort of disillusioned, thinking that what they're working on and what they're recommending is not going to help anyone because people are not listening to them. So I think this is a huge problem that's really gotten much worse as part of the pandemic. And so when I saw this call for the panel, I thought that I wanted to contribute some of my thoughts about what I've been noticing over the past few years as well.
Thank you, Dr. Gorman. Dr. Jackson Preston, would you like to add?
Sure, good morning. So what drew me to this panel, I've been interested in well-being ever since going through my own chronic illness episodes over a decade ago. And so prior to the pandemic, I actually was just in the launch mode for this study of staff in higher education and just really trying to understand what factors were contributing to or worsening their well-being. And so to come into the pandemic right off of that and just kind of see the need for this work explode as a public health professor, I didn't give my background. I'm an associate professor of public health at Cal State Fullerton. And I also am the CEO of Empower It to Exhale, which focuses on sustainable wellness and performance. And as I've been working with different audiences, a lot of my work has focused on helping to think about, as we continue to launch and expand initiatives to serve others, how are we sustaining the people who are doing the work? And that's across sectors. So I think the need has become even more amplified. And honestly, anytime someone is willing to pause and say, wait, let's look at how we're doing. Let's look at the people that we're sending out. Let's make sure that we're not taking advantage of this sense of I'm willing to serve at all costs, even at the cost of my family and myself. So anytime someone's willing to take a critical lens like that, I'm happy to be a part of the conversation. And thank you for the honor of having me here today.
Thank you. And I'd just like to add as well, although I'm a moderator, I also am a researcher here, community engaged researcher in Arizona. And we conducted about 77 focus groups with a variety of individuals here in Arizona. For SEAL, we focused on African American, Native American, Indigenous, Hispanic, Latinx communities. But we also focused on a number of other populations, mothers, seniors, things of that sort, through another commissioned project. And I have to tell you, by the time we were done with those focus groups, there were participants who were no longer with us. And being a part of the team that did the data collection, reaching out to individuals, knowing that this was a time of great uncertainty, as well as very, politically charged times when it comes to viewpoints on COVID. I really felt committed to take the research and the knowledge back out to the community. That was my promise to those that participated, is that if they trusted me to sit with them for an hour or hour and a half and listen to their stories and hear their stories, that I would take those stories with me to the community. And these individuals not only were our demographic, if you will, that our targeted group. Those that stepped up often were the helpers, were the ones on the ground, convening, communicating, connecting. And so these are the individuals that we're talking about today. And for me personally, it caused some burnout, I have to say, talking with that many people over the course of a year and a half. However, we do self-care, right? Or we should. But that was just my personal example. I'm wondering from you, and anyone can jump in here, right? Anyone on our panel can jump in. So don't wait for me to give you the nod or turn it over. Go ahead and jump in. But I want to start with some stories and ways that illustrate the variety of ways in which burnout shows up in our public health workforce. You've mentioned a few. I gave you an example of me as a worker, as a researcher, but maybe there are other examples that you can share about the way that burnout shows up for the public health workforce.
I would love to start with talking about our students and the future of the workforce. The secret's out, they're watching us. So every time we neglect our care, they absorb that as professionalism. They think, if I want to be successful, I need to replicate what you're doing. And so right now, the things that they're thinking about, can I start a family and do this work? They're watching us reluctant to retire. because the older generations are nervous about what is to come and often reluctant to hand over the hands of leadership. And so they're norming and performing, and they're distracting themselves. We're seeing it already in turnover in health departments. I'm seeing it in the classroom. And I'm very concerned because we don't have anything that resembles caring for ourselves as a part of our core curriculum. And yet we go out into the population and we essentially tell people, hey, don't do what I do. Do this. This is what the research says. But if the research doesn't actually translate into practice, does it matter? So my deepest personal concern, I would love to see people bring this up with CEAF and say, hey, we actually need to start practicing what we preach and get this in standards. So that for me is where I'm seeing it the most. And I'll let someone else go, but thank you for allowing me to share that.
Thinking of a couple of experiences from my sort of professional work in the last 2 years. Professionally, I'm a medical librarian. I've worked at a number of organizations, educational institutions around the Philadelphia area, with a variety of scholars, including some people who are, in Philadelphia, highly invested in public health, in, sort of substance use, in HIV/AIDS, in, sort of health disparities in West Philadelphia, those areas. And, they are awesome and they try so hard. But, I remember one particular meeting I was in, it was discussing a paper we were writing about COVID denial, and one of the researchers, who to me was, she was so impressive, she was so driven, she was so kind of productive and smart, was just, almost broke down, saying like, and this was just after sort of the Dobbs ruling, was like, I just, it's just so hard, it's like so hard. We're climbing a mountain, the mountain gets taller, I don't know if I can do this anymore. And, she wasn't looking for anything, she was just letting us know how she was feeling at that moment. But it was important to me to sort of reflect on the value of what she did from my perspective, just on an individual level, and just supporting her in an individual way and being there for her and saying like, it's incredibly hard right now, but what you do brings so much value to people who need it, that I just want you to reflect on that sort of, particularly because she was in the Jewish tradition, we talked about sort of tikkun olam, which is kind of like, sort of the saving one person is saving a world, those sort of concepts in Judaica, which are matched in other faith traditions about, what it means to help a person, rather than kind of thinking about it from the academic perspective or the career development perspective, or like making huge changes in society, which is something that, is the only solution to most of the public health problems that we face, is sort of radical wholesale change in the way that we structure health and society. That is too big to talk about in encounters with people when they're vulnerable, when they're feeling emotional, and, finding ways to just authentically approach people and ask them, it's hard, how are you? I think is something that we give, we don't do enough, and we should do more of that.
And I would like to say that the Bridget Austin Community Center partners with numerous agencies, public and private. But I just want to talk a little bit about our partnerships with education, both the secondary schools, primary schools, as well as the local colleges and universities, and even the community colleges. We reach out to them all because we like to bring expertise in. But I just want to talk about the term that was thrown around for about 3 years in various ways, the term essential worker. And to have been labeled an essential worker, well, you know, you were so proud to be called an essential worker. I'm needed, I'm necessary. But what did that really look like during the darkest days of the pandemic? Everyone did not have the privilege of being able to work from home. Some people, after a very short period of time, it was demanded that they come back, even though things in their own home, in their personal lives, may not have been as stable and secure as others. And so that's magnified in the community in which we serve, where poverty already looked like real poverty. So, in the context of COVID, how did that look when people who could barely, afford the rental or the mortgage or to transport just any major line item in their budget? What did it look like when you had to leave your children to go as an essential worker and serve the public at large, and then things began to fall apart at home? So, although we talk about the people that walked away from education and that turnover, and we know that in our area, 54% of the teachers or educators leave within 5 years now, and that's not getting any better. But we don't talk enough about the people who stayed and what does that look like. They work longer hours because of the people that are not there. Okay, they don't get to take a break. They didn't get the privilege of the 2 years of working from home. They already didn't have enough, and now that people are beginning to come back, it is as if it is forgotten the sacrifices that were made by that group of educators at all levels. And I don't know how we get that energy back. A major initiative needs to be in place now to just say thank you to those who stayed.
Yeah, and I agree with that. And, that you make some really great points, Dr. May. And, I remember a story from a man who actually is no longer with us, unfortunately, and talked about, having to balance the safety of his family and his children with the needs of the children from the community. He happened to be an African-American male. He was an administrator at an alternative school, and these children did not have access to the technology they needed, and they didn't have the family resources the parental resources to really get that. And felt like, he showed up. It was his mission to serve this underserved community. And so having, really feeling that tug of, do I stay home and shelter in place, or do I go out and get these kids what they need, even though I risk, contracting COVID and spreading and so on. And, he also shared that it wasn't, speaking of caregivers, he shared that it wasn't an expectation of the job, such as an essential worker. He didn't have to do that. But because of his commitment to the community and his position as a known leader, for these children, or these young children, that he was compelled to do this because no one else did. And he felt that because no one else did, somebody needed to. And if it wasn't him, it wasn't going to happen. And so these are things that, stories that I heard over and over. And again, he had some comorbidities and he's not with us. And these are some of the consequences and ways they show up. There are other examples. I'm wondering if Dr. Gorman, if you have anything you'd like to add.
Yeah, I think I'd like to go back a little bit to some of what I think Richard was getting at, which is that there's been a real, as we all know, intertwining of public health and politics in the past several years. And I think that is very difficult for the public health workforce. And for example, coming from my organization, We train people to do interventions on social media about misinformation about health topics. And one of the new topics that we're looking at is reproductive health. And because of what has happened in our country related to that recently, it can become a very politically charged interaction. And I think that the conversation ends up being more acerbic, more bitter, because there's those politics woven in when they weren't as much before. And so even with COVID vaccines, there's a lot of politics, and masks, there was a lot of politics. And so I think that can contribute to, ultimately feeling like you can't do your job because you're overwhelmed. It's very unpleasant, and nothing really prepares you in public health training for dealing with those kinds of comments. So I think that can cause a lot of distress, and it can eventually cause people to feel helpless and burn out.
May I add to that? I think you bring up such a good point, and what it extends to for me is the sense of people practicing public health as their identity. When you are not good at something that you think is your purpose in this world, that hurts you at a deep level. And I can remember stories of people whose marriages were really weathered by the pandemic because they were so committed to this, and they did not know how to disconnect from what felt like a massive failure to care for themselves, to care for their children, to care for their responsibilities. And at the end of the day, they had to learn how to come up for air and accept that the work would never be done. How are we going to continue to weather decades of this work with that? It's not sustainable. How do we begin to recover ourselves and to understand that this work is an extension of ourselves, not the basis of our identity?
I want to bring bring attention to Audre Lorde's quote: "Caring for myself is not self-indulgence. It is self-preservation, and that is an act of political welfare." So we know that the contributors to burnout are many. And I'm just wondering, and I'm going to send this over. I was going to ask Dr. Gorman, how do you handle self-care? What are some of the challenges when self-care seems trite, or it seems as if it is against the culture of self-sacrifice, if you will? How do we handle that challenge?
Yeah, that's an important question. There tends to be, if you just Googled burnout, you would find a lot of articles about self-care and yoga and meditation. And this tends to be where the level at which the discussion takes place. And those things are definitely important, because the more individuals build up resilience to things that come up in the workplace or in their careers that are stressful, the better off they'll do. But sometimes when people, that's their only tool, they're just sort of kicking the can down the road, because there are deeper structural issues, some of which we just spoke about, that are resulting in more people having burnout. And one of the biggest things in the pandemic was, I think, people felt abandoned by the entire public health system in the whole country, because they thought, why weren't we more prepared for this? Why didn't we respond better to this? And I think people felt a little bit of less confidence in the profession because of that. And that is, in order to solve that problem, we would have to really take a deep look at the structures and the systems that we have in place to deal with emergencies like a pandemic, because I think we know that there's going to be more down the road. And if it was that disruptive to people's ability to do their jobs, we have to know how to handle it the next time around. But there's just not a lot of confidence that anyone's really looking at the culture of the workplace. Like you said, dealing with this issue where it's communicated to people that self-sacrifice is the most important thing. We have to change leadership styles around those messages. And that's harder to do than telling people to, just take a yoga class.
Right, because the suggestion, take a yoga class, meditate, or take a bubble bath. These things may help, but they just they don't feel as if they're solving the problem, if you will. So How do we encourage that as a system?
I mean, one thing
Also,
go
ahead. Go ahead.
I was going to say one thing in the, I work in, previously worked with, hospital-based nurses, and it had come to the point where institutional sort of talk about resilience building and mindfulness was just, the nurses would just mock that. I mean, it was just such a farce, so absurd, kind of the sense that institutions are very keen on mindfulness interventions because they're basically free. They put the onus on the worker to engage in that behavior, and it doesn't call for any sort of meaningful change by the institution. It doesn't really call for any meaningful inputs by the institution either. So one of the things that I have thought is significant, has been significant for me, it's been significant for people I've worked with in the community, is in some senses becoming more engaged outside of the professional role, becoming politically active, engaging in advocacy work, doing things that are outside of the vulnerabilities of your professional identity, your affiliation with an employer, all of those things that, both keep you in and also perpetuate the systems, particularly systems of oppression, going outside them, becoming involved, working with a mutual aid organization, taking part in, street protests, going to school boards, like whatever is comfortable for you. I had remembered like a couple of years before the pandemic, I took a couple of NICU nurses to DC for an advocacy event, and they were feeling, before we went, quite used up and burned out, and to some extent they came away from that advocacy meeting with a better understanding of like what was happening because of what they did. Like they never saw dramatic improvements in the health of any particular one kid that they took care of. And I think you can sort of walk this into public health settings too. It's very hard to sort of change the system, particularly from the inside, but trying to change it from the outside can be inspirational.
May I tag on to that? You said so much. I'm sorry. There was so much good in what you said. And the first part I want to talk about, self-care is not this either or. It's not, oh, if we say self-care, then, we don't have to do anything. You care for yourself because you're worthy of care, period. If your employer neglects your care, you still care for yourself. Yes, we have an institutional obligation to do better, but I'm a little concerned in what I've seen, which is people neglecting to care for themselves because they're waiting for other people to tell them that they should. So if we want to get this ball rolling, we actually have to build it on a foundation of caring for ourselves. And I think that's what Audre Lorde was talking about. So it's not that, hey, as long as you do these things on the surface, you're good, keep going, do the work. It's no, I actually need power and sustainable energy in order to disrupt the structures that I believe need to be changed. So when I go into organizations, I use a framework where people first look at the foundation of themselves, their physical and emotional health. Then they look at their spiritual and their social health, not spiritual just in the context of a faith, but what is my connection to this world? What is my sense of meaning and purpose? And so for some people, this mixture of emotional and social wellness will be advocacy. For others, it will be, wow, I work all the time and I frankly just need to rest. It's learning what works for each person. Then when we get to this outer layer, do you have hobbies? Do you have this sense of curiosity that you're nurturing, or have you lost all aspects of yourself except for the work? And once we've covered those foundations, we can really think about now, how can we be of good to the world? But what we've been doing is backwards. Let's do the work until it's done, and then we'll care for ourselves. So we can't wait for the system to wake up and say, hey, this is the way we should do it. We have to start disrupting within ourselves first, and then we can help each other. And I think that's a more sustainable way, because most of us who've been in public health for a few decades have seen nothing happens overnight. The fight for tobacco legislation took decades. What we're doing right now with chronic disease, frankly, I think we're learning and we're making a lot of mistakes. And 20 years from now, it will look completely different. So let's take the same long-term range view of not just self-care, but this broader wellness that is multi-level, and think about what place we need to be in to sustainably fight for that change.
One aspect of health and wellness in our community that is very difficult to talk about, and often I feel as if we are somewhat in denial, and that is the issue of mental health and violence, even among children, and how we are just now considering it to be problematic, when anyone who has been in education for any period of time, you know that one of the main reasons why the turnover is so great has to do with the management of people and the management of emotions and the relationships and the interrelationship between parents and educators and children, and how the community views the roles and what input can the community come in and demand of people who are already burnt out. It just seems like the community is demanding more, but we're not giving the people who are the object of all of that pressure the tools that they need to be able to make it through the day, let alone to make it through the year. And so in terms of the mental health crisis, I would say that if we work on the burnout end and the preventive measures first, because right now we're just putting a Band-Aid on people bringing guns to school and shooting a teacher. We're trying to fix that by removing a superintendent. That didn't happen overnight. That whole system, that's a construct of someone who was valid enough so that even his parents knew that they had to come to school every day. And as an educator of almost 40 years, I can tell you, I have never had a situation where a parent was required to be at school in the classroom with a child every day for that child to be successful. So that did not happen overnight. And I just think we're reacting rather than backing it up and trying to put some safeguards in place for the livelihood, for the health and the wellness and the survival of those that are on the front line. Just because they're an essential worker, that doesn't mean that they're dispensable. And I think that we're forgetting that when we put too much pressure on any one entity, then we're bound to lose that whole group. They have no more trust in the administrative capacity. They think that all that we demand from them, they're not getting enough in return, and money is not just money alone. Giving more money is not the solution. It helps, but it is not the solution. So I just wanted to add that.
You know, I appreciate that, because you really have identified some, individual ways individuals can begin to change and take care of themselves, and ways that we need to look at this from a systemic view. And that's very important. What I always worry about in the way that we, and some of the questions we ask, I feel as if we ask individuals, well, how would you like information, and what, from a cultural lens, how would you like this information, or what works for you? And in some ways, we that feels as if we are putting the expectation on them to change, this individual to change this structural issue. And I'm always, wanting to be careful of that. And at the same time, I agree with you, Dr. Preston, that we absolutely need to begin to disrupt our own process. But then again, as you mentioned earlier, to be successful, quote unquote, we have these norms that we're seeing and emulating. As a doctoral student, you know this because you've been here, the type of pressure you endure under that culture, if you will. And I have teen girls, they're watching, right? So just as you said, so I just don't always know how to balance that. And you spoke to that to some degree, but I'm wondering if any of you could say a bit more about how do we balance that personal responsibility, right? And that structural accountability as well, and disrupting on these various levels.
Dr. Carver, thank you so much for that, because I actually want that tension to sit thick and heavy on your heart. Not because I want you to be in pain, but because when you surrender to one or the other, you're no longer in reality. There's always going to be, this is not public health. This is like our global culture. You have been taught to see yourself as always needing to work for worthiness, always needing to work to be enough. And so no part of this world wants you to sit and be comfortable and say, I've done enough, I am okay. And you're always going to have to fight against that in the culture of your organization. And the reason I stand here and say the disruptive things that I do now is because you're right. I did have to go through all of that as a student. And now that I have tenure, I can sit on the other side and say what I think. And the more of us that are around to do that, the better. But here's a sobering point. I know so many Black women who passed away in academia in their 40s and 50s. Let that sink in. So how do I stay here to continue to disrupt if I don't care for myself? I have to always have that fight. And every single day, there's so many things as a business owner and as a professor clamoring for my attention. How do I choose to say, you know what, today's not the day where I'm going to work all night. Today's not the day where I'm going to be the 24/7 therapist accessible to everybody. That has to start with me. And as I start to embody that, and I like really just see the rest of my career, honestly, as a healing journey. Heal me first, and then the ripple effect is I can start to heal the structures around me. So I think that tension is so important and honest, and it brings a lens of transparency that we have not had, because we really, I think the manpower of the public health workforce is getting people to buy into martyr syndrome, getting people to believe that as long as I lean into the positive aspects of being a helper, that is going to somehow outweigh the negative. And what my research showed in higher education professionals, the negative aspects of being a helper, which we called compassion fatigue, that was associated with poor mental and physical health. And compassion satisfaction, those positive aspects of being a helper, did not mediate that relationship. So we have to be able to start questioning and turning around that narrative. And that's why I'm actually really excited to hear you call up that tension and to say that there's not an easy resolution.
In that context, and it's not easy, but I am outside of academia. I have my professional role, and my role in sort of advocacy and research is personal. And so, although I put a lot of value in it, I could walk away. I mean, it would have repercussions. But it wouldn't have financial repercussions. It wouldn't have professional repercussions. And I certainly did that, much earlier in my life. I came to the States to live in community with homeless folks in a sort of a couple of organizations. And I did that for 4 or 5 years until, I just eventually realized that it was enough, right? That I wasn't enriching myself or others, I wasn't a positive sort of presence in these communities, and I left, and it was hard, but that is something that is available to some people. There's an amount of privilege that's involved in that in the professional, because people do walk away from their professional roles because of burnout if they can. But many people can't, particularly sort of marginalized folks and minoritized folks. But on the sort of the community stakeholders part, it's important, and some of our organizations have sort of let community and family stakeholders know that you can leave, you can stop, and we won't break ties with you. if you need to sort of step away for 6 months, for a year, you can do that, but you won't be dead to us, right? We'll still have a relationship. We'll welcome you back with open arms. And some types of organizations and some kinds of work can accommodate that. It's very hard to accommodate that in sort of professional roles in academia, unfortunately. That's just like knowing when to stop.
And thank you, thank you both, actually. Dr. Gorman, when you say you teach individuals in regards to social media, and who do you teach? Do you teach the community on the community level, or who's your audience there?
Yeah, so we always identify certain communities where misinformation about a certain topic is more problematic. And then we actually recruit from within those communities for a person or people who get trained in our method of combating misinformation. And then they run these interventions on social media when they see misinformation that's particularly salient, that's very widespread. And it's based on sort of a psychological practice called motivational interviewing. So it's you have to be very patient, and you have to be very willing to continue talking to someone who in some cases may not be that open to talking to you. And so it's very challenging. And actually that was something that we picked up on early on, that we call them infodemiologists, that they needed more support week to week. And even in terms of getting quick responses when they're working on an intervention, because they would sometimes just have an emotional response to doing this and feel like, I don't know if I'm doing this right, or this person seems angry. And it was really helpful when one of us was just there to answer them on Slack really quickly, like, keep going, like, you're doing great, and, or give them an actual suggestion. So some of it is just having that ability to be in this type of work, to be very responsive, but it can be a little bit time intensive. So we're trying to figure out ways that it can be scaled and workplaces where people have less time.
And I think of, we've talked a little bit about academia, we've talked about teachers, and your infodemiologist. I love it. I'm thinking about here, like in Arizona, we have a, large contingency of promotores, community health workers, individuals who are, health aides and paraprofessionals. Do you have ideas of what they can do from individual and systemic level? They may not be able to, or feel that they can make the sacrifice of committing to an advocacy effort because of their time or resources and responsibilities. But what are some things that you think can be done?
I think one thing is, I think they actually can participate in this kind of intervention. It can be done in a much lighter way, which is just like an in-person conversation, to have some tips about how to talk to people who might be showing resistance to things that you're trying to do, like get people vaccinated or anything else like that. So there are opportunities to do that. And I think when health departments recognize, when we've spoken to health departments, they immediately say, oh, we have many people who would want that support because they're dealing with kind of misinformation and vaccine hesitancy every day, and they don't have a lot of tools. So they can be trained in a light version of doing that. But I also think outside of that, maybe just helping people to understand what the modes of influence are within a certain community, and identifying the people that they should talk to first is often a good strategy. So just embedding that in more work that people are doing in communities, whether it's hospitals, health departments, et cetera, that can make a big difference in the health behaviors of the whole community.
May I add a thought to that?
Yeah.
Okay. I worked for Susan G. Komen before becoming a professor, and I was in an advocacy role helping Black women promote breast health awareness. And what I saw a lot in that space is, if you are a member of the community that you're serving, and they are in a predicament where many of them are going through late stage breast cancer, there was a tendency for ourselves as advocates to look at ourselves as, wow, I have so much, I need to give everything I can to help these people. And you're so focused on saving their lives that you're not really conscious about what you're at risk for. And so watching people work to the point of burnout, you can still look at someone and say, yeah, but they're struggling more than I am. And I bring that up because I think that happens a lot with our lay health workers. This is an opportunity for them to lead and to contribute something valuable to their community. And sometimes that can obscure the need to also prioritize caring for themselves. So I think there's a lot we can do in how we are training them and checking in with them to make sure that their health is prioritized as part of a sustainable approach to serving their communities.
Thank you. So I'm going to ask, in terms of research and reciprocity, as we do our research and we communicate our outcomes and our strategies, we get these experiences, learn of these experiences either directly or from the communities that we're engaged with. How can we demonstrate reciprocity and really honor those who are on the front line doing that community engaged work?
Ask them what currency is of value for them, because we often, like in academia, there's certain things that are valuable, there's certain things that are currency. Those things are not currency in the community, like an author position, an H-index, all of those things are meaningless, or they might not be. Some people may be like, it would be amazing to have my name on a journal article. It's hard to tell without asking. And I would feel that, going out and saying, what is it, how can we recognize you, is really the only way of getting to that, rather than just sort of workshopping it internally, from our own position, is going to make it, it's probably not going to be right.
I would add to that, when we do our research on stress coping in communities, we often ask people, what are your greatest stressors in this role? What are you doing currently to cope? And what resources do you need? So all of that boils down to, what do you need? And I think the first couple of times you ask people, they're not going to say always, I need this, I need that. Because again, we've bred a culture where we're invisible. And somehow we magically care for everyone without caring for ourselves. So we have to show up consistently and say, hey, we realize that we have a problem with reciprocity. And we want to be transparent, and we want to cultivate hope among our people. We want to make sure we see ourselves, because we're going to be more effective in our work if we do. And if they see that we're serious about that over time, I think we're going to start to get more honest answers. I think anonymous feedback loops are important, so that people don't feel like they're going to be targeted for being high need. Or seen as selfish, because again, our culture reinforces that. But I think that we should not ask questions unless we're ready to respond to them. So I'd rather see people go slowly and be honest about what you can and can't do, what is a short, medium, or long-term goal, because that's going to cultivate the trust that you need, which we all know is paramount to community engaged research.
Great.
And as a change agent, making certain that every voice is heard. I think we can do a better job as becoming better listeners, and making certain that the voices of the ones that are the most at need come to the table, that you bring back something that is more tangible than just words when you come back to your participants. There has to be something that if you're a change agent, there has to be something that you're saying or doing that is going to make it better. And again, I go back to not just putting a Band-Aid on it, but a change agent that's really going to make it different and better than it was, because you're there.
I would just pick up on some of what Portia said. I mean, even even trying to give some examples, but not putting words in people's mouth, but some examples of things that they might want or need can be helpful, because like you said, I think a lot of people feel like they go blank when they hear that question, what do you need? It feels vague, and they haven't thought about it enough for various reasons. So I think giving them some ideas, like, would this be helpful? Would that be helpful? What else can you, like, we'll just start the gears going so that they can really start thinking about that question.
Yeah, I really think, I go back to what Dr. Preston had said about permission to self-care, and kind of waiting for individuals to give permission. Well, it's not, you never knew you could ask. I mean, you never knew you could just take that liberty, right? Because it's not part of the culture. So I do think creating those spaces are important, where you don't even have to ask permission. It is a expectation of the space for which the environment in which you work. It is really important. And then modeling, that's important as well. And depending on where you are, it might be, you may have a huge audience, or you may only model in your, small, immediate context. But I do think that's an important way. And then recognizing that different communities need different things. It might be, the currency might be just trust, if you will, in that the expectation of follow through, and the expectation of responsiveness, maybe currency in some ways, even though it's not monetary. When I contacted a community that was more rural, and they basically who are you and what do you want? And you only knock on our doors when you want something, and then we don't see you. And so to them, currency was, you keep us in mind, you get to know us, you build a relationship with us. And that to them was paramount. Now, additionally, what I see are, when we get into those situations, we've asked, for that particular case, we did some work up there, and one of the professionals said, no, don't, who spoke, no, I don't pay me. And it wasn't the community agency that had the budget. And I remember sharing with that person, please don't do that. Please get something, because it's worth it. And it perpetuates the expectation that you are going to do this on a weekend, while others are paid, that because maybe you have some affinity to this group, you will and should do it for free. And so I think those are some things that come to my mind with reciprocity, and like I said, currency. I love that. So we are at the end of our questions, if you will, of those questions that we had written out. But I do want to ask the panel to share their thoughts and comments, things that maybe we haven't touched on, that you feel are important in terms of caring for caregivers in community partnered research and reciprocity.
I would love to just follow up to your wonderful points. I will say, if we come in and we ask, what do you need? And we aren't sincere about our motivations, they're going to know. So that's the first thing. I want to caution everybody, this is dangerous work. You can't walk around pretending to care. So the first thing that we should be doing, we should be checking ourselves before we go into a community. Am I here because I want to get a manuscript through? Am I here because I want to improve your community in the way that I believe is best? Or am I actually coming to you saying, hey, I have some thoughts and I want to check. How does this line up with what you want for your community? How does this line up with what you're already doing? Am I knowledgeable of your world, or am I just asking you to make time for what I think you need? So we have to check how we're coming to the community in the first place and be willing to modify our approach. And that's going to look drastically different from what we were all taught to norm to in this field. The second thing I want to offer is a resource I'm happy to share. I do have a plan that people can download for free and use. And I say that because I don't care, honestly, which one you use. There's a lot of them out there, but we need to make more resources available for free so people can sit and have conversations and talk about this further. So I will work with Dr. Carver to see how that information get out to you all, but I do have a few free things that you can use to start a conversation and to determine where your community needs to go next.
Excellent.
I want to add that several of the people that I invited to come to the seminar today, and they are texting me. That's why you see my hand coming back and forth. First of all, they're very appreciative of this opportunity to have their voices be heard. So many people talk at them and to them, but then they don't really listen and take back what they really need that is going to help them. I just want to write just a few comments of what I have received. Some people are really on the brink. They're in the battle of their lives for their families, for their institutions, for their own health, for their wealth. We have some caregivers that are taking care of 3 generations at the same time. There's one lady that's on here now. She's taking care of her mother, who is in hospice. She's taking care of her husband, who just had a stroke, and she's taking care of her children and grandchildren. So really, everybody is taking a chunk out of her day. And at the end of the day, there's nothing left for her, but she's a leader in several organizations. So what does that look like for her at the end of the day? What does she have left? And I'm saying that's just a slice of our community. But if you multiply that, the schools that we serve, the churches that we serve, the attrition among the educators, the nurses that are walking away in droves in Metro Atlanta, the hospitals, plural, that have closed. And therefore, we have one person that's on here that said that she went to the emergency room just 2 days ago and was there 17 hours before she ever saw a doctor. And it wasn't the fault of the hospital per se, it's a construct. And until we understand that this idea of being a change agent and of really serving the community, there is so much administrative fog or it's like a cloud that you have to go through to really figure out how you're getting the right resources, the time, space, and materials to the right people. Because if we really are in the business of serving the community, there's work to be done, but it's almost like we get in our way of helping others. And I just want you to know that some of the people that we've all been thinking about and praying about, they're on here and they're listening. And they're hearing that there are people such as yourselves that are out there that are willing to help. And so thank you, Dr. Preston, that you have a plan that's in place that we can download. Certainly, we do need ideas. We need boots on the ground. We're all essential workers doing essential work. But just know this, that at the end of the day, there are people that don't have very much left at the end of their day, at the end of their week, at the end of their month. There's no money, there are no resources, there's no time. So that's what we're facing. And so thank you for allowing them to come in and to just hear a little bit about what everybody else is doing, in addition to it being my pleasure of serving them as the executive director for our community faith-based organization, the Bridge at Austin Community Center.
Thank you. I think we all are so appreciative, and I wish we had time to really engage with our audience further, but I do think we need to continue these conversations. we want to make sure that you have the, you know, a way to identify, to find the resources and researchers and community professionals here. And so hopefully that contact information will be made available, or those resources will be made available through CEACR. And Dr. Gorman, did you want to add anything to the conversation before we wrap up?
I have just been thinking about in public health and maybe medical education as well. I feel like there needs to be a course that is something like how your expectations will not meet with reality. Because I think if we could prepare people, and what we've learned from the pandemic should be part of it, assuming that there's going to be more emergencies like that, which there will be, there should be some recognition on the education level for professionals going into these fields about what happens to our healthcare system when something like that occurs. And, you know, what are some ways, what are some things that you might feel, and what might, you know, and how can you start to even plan ahead for something like that happening? I think we do people a great service to be more prepared in every way for situations like that.
Good point. And Richard James, do you have any last comments you'd like to add?
I don't want to be the last voice in this room. You know, Dr. Jackson-Preston, Dr. May, Dr. Gorman, I think they have said what needs to be said, and I don't want to capstone that because I'm not capable of. Thank you.
Thank you so much. So I want to turn this back over to Caesar, because I know that, you know, there's some wrap-up comments and there's some future opportunities to engage in these types of discussions. Hopefully this is not the last. We know that this is a huge issue for community and individuals on a number of levels. Someone mentioned in the chat that, look, you know, the hospitals and acquisition of these companies and hospitals is causing disruption, or, you know, difficulty, and contributors to burnout. And there's so many different facets of this. And there's, like I said, the clergy, and then there's the promotores, and there's so many levels. So hopefully this is not the last session. I'd like to go ahead and turn this back over to the our host. And I also want to give a sincere thank you. I know that you're here because it's important to you personally. This is an issue. Some of the times we go to our communities because this is what the grantor requires of us. We may not have any connection to the community. But I think asking the questions that Dr. Preston asked, shared of ourselves, why are we doing this? Are we authentic, sincere, is important. And to make sure that that grantors that are selecting, you know, those to do business with, also are asking the right individuals with the right motivation to do the work. With that, thank you so much for your time. I'm turning it over. We have 2 minutes.
Thank you so much, everyone, to all of our panelists, our moderator, Ann Carver, our interpreter team, as well as our audience members. We encourage you to visit the CEACR website. I just put that in the chat to submit a consult request or serve on an expert panel. We would love to learn more about your community engaged research and ways that we can support you. And please take a moment to offer feedback on this session. Before you leave, there will be a poll that should be coming up. There you go. Please just take a moment to fill that out. And thank you again, everyone. This was a really wonderful discussion. And we hope to see you for our future events.
Thank you.
According to NBC News and the filings for the tape, white world hammers we saw are gloves.
Oh.
Thank you.
Thanks,
Thank
everybody.
you so much.
Yeah, it
See
was
ya.
really, really fantastic discussion.
Thanks, everybody.
Everyone for bringing wonderful insights.
Super great. Oh, thank you.
Bye all.
Yeah, thank you.
Thank you, everyone. Take care.
Thank you, Dr. Preston.
Thanks, Portia.
Yeah.